Welcome to another MedTech Gurus podcast, where we meet and discuss trending and educational topics that are important to today's medical technology sales and marketing professionals. Now, it doesn't matter if you're new to the space or if you're a seasoned medical sales and marketing professional. You all have come to the right place. You see, the medical technology world is ever changing, and MedTech Gurus will help you stay up to date by interviewing experts and opinion leaders. Now, we call them gurus, and they will bring you information, techniques, and strategies that are sure to help you enhance your knowledge and help you bring value to your customers and your company. Now, I'm Sylvester Harris, and I'm pleased to introduce your host for MedTech Gurus, Mr. Tom Hickey.
Hey, what's going on out there, Gurus? This is Tom Hickey, your host of MedTech Gurus, and welcome to episode number 263. Today, we have two exceptional guests who are revolutionizing the field of bariatric surgery. First, we have Dr. Jon Schramm, Section Chief and Medical Director of Bariatric Surgery at Corewell Health. With a distinguished career, Dr. Schramm has been pivotal in advancing surgical techniques and improving patient outcomes. He is also a lead author on a recent study published in Obesity Surgery, showcasing the clinical benefits of the Titan SGS stapler. Joining him is James Ferguson, President and General Manager Surgical at Teleflex. James has a robust background in medical device innovation and played a key role in developing and commercializing the Titan SGS stapler. His career spans multiple leadership roles where he has driven product innovation and market expansion and operational excellence in the medtech sector. In this episode, we'll dive into the evolution of gastric sleeve surgery, explore how Titan SGS stapler is setting new standards in bariatric surgery, and discuss the impact of GLP-1 drugs on clinical practices. Get ready for a fascinating conversation filled with cutting-edge insights and practical takeaways from two leaders at the forefront of surgical innovation. But before we get into the episode, let's thank our sponsor, Accelerant Consulting. Gurus, GPOs, RPCs, IDNs, it's also confusing. Where do you start? Let the experts at Accelerant Consulting guide you through today's complex healthcare market. Check them out at accelerantconsulting.com. That's EXCELERANT consulting.com, and do it today. Okay, Gurus, here it comes, episode number 263. And remember, if you like what you hear, please subscribe, leave a review, and most importantly, tell a friend. Welcome, MedTech Gurus. Today, as I mentioned in the introduction, we have two terrific guests with us. These two gentlemen are at the forefront of innovation in bariatric surgery. Dr. Jon L. Schramm is the Section Chief and Medical Director of Bariatric Surgery at Corewell Health. With a distinguished career in bariatric surgery, Dr. Schramm has been instrumental in advancing surgical techniques aimed at improving patient outcomes. He is also a lead author on a recent study published in Obesity Surgery, which explores the clinical benefits of the Titan SGS stapler. Dr. Schramm completed his bachelor's degree at Calvin College in Grand Rapids, Michigan, and his medical degree at Vanderbilt University School of Medicine in Nashville. He completed his internship and residency at Michigan State University in affiliation with Corewell Health Butterworth Hospital in Grand Rapids, Michigan. Joining him is James Ferguson, President and General Manager, Surgical at Teleflex. James has had a robust background in medical device innovation, having led the development and commercialization of the Titan SGS stapler. His career spans various leadership roles where he has driven product innovation, market expansion, and operational excellence in the medical technology sector. Hey, Jon, are you ready to be our guru today?
Yeah, looking forward to it.
Well, that's fantastic. And James, are you ready to be our guru today?
Absolutely.
That's great to have you fellas here. So let's just jump right into this. First of all, Jon, I'd like to start with you.
Sure.
You've seen firsthand, the evolution of bariatric surgery. And I'm wondering if you can provide our gurus out there with an overview of gastric sleeve surgery's role in managing obesity and discuss perhaps why it still may be underutilized despite its benefits. Can you help us out with that?
Sure. So sleeve, probably for the last 10 years, has been the most commonly performed operation for bariatric surgery for morbid obesity. And it started as kind of a a pre-surgery or a part of the procedure that was done when we did duodenal switch operations. And it turned out that when we would just do the sleeve instead of doing the whole switch, the results were really, really good and had the huge benefit of being much less lifestyle changing than the traditional bariatric surgery would have done, whether it was duodenal switch or gastric bypass. So it rapidly became a very popular operation. Patients could see the results, which were very similar to more invasive, more complex operations, but had a higher safety profile and had less after effect lifestyle changes. So it quickly became the most popular operation, and today accounts for probably anywhere from 70 to 80% of the bariatric surgery that is done today, primary bariatric surgery is done today.
Yeah, got you. Thank you for that. And then, James, with Teleflex, what was behind the development of the Titan SGS stapler? What specific challenges did you see in the gastric sleeve surgery that this innovation was able to address? Can you help us out with that?
So I think it's important first to go back to the inventor, which was Dr. John Thompson. So one of the things, this was really at the precipice of when sleep gastrectomy started really to evolve from the standpoint of becoming that standard bariatric procedure. And so he looked back at the 2012 consensus conference and looked at sleep gastrectomies and noticed a significant variance. When you look at leak, you look at GERD, strictures, and said, these are all technical issues, right? These are things that are really driven by the tools the surgeons have in their hand and not necessarily about the surgeon themselves. And so he looked at that and said, how can we improve that? How can we create consistency? And a lot of that was focused in on looking at the critical landmarks of the stomach to really focus in on creating that optimal sleeve shape, that tubular sleeve shape. And so it was really the foreseer of this technology coming to fruition, starting with the clamp and then evolving into a full-fledged stapler. And so really exciting innovation, and one now we're starting to see that vision, that innovation come to reality.
Yeah, it sounds interesting. And if I've got this right, it sounds like perhaps it was just a drive to minimize some of the variables involved in that surgery to drive to quality. Am I heading down the right track with that?
Absolutely. Absolutely. Yeah. And I think, Dr. Schramm he lives it each and every day. So he clearly has the ability to understand how, it's not about the quality per se of the surgeon. If you have the right tools in your hands, it can really drive those optimal outcomes that he's striving to achieve each and every.
Yeah.
Years ago in Michigan, we actually tried to look at, the most optimal sleeve technique. And so we actually did video reviews of probably 24 surgeons in the state of Michigan to try and identify the optimal technique. And there were literally 24 different ways to perform a sleeve gastrectomy. Nobody was doing it the same way. And to be quite honest, even though it seems like it would be fairly simple to do the same operation, everybody does it a little bit different, and the results were not always the same. And if you can create a better sleeve, you have better results. And really all the work that John did early on in developing an anatomy-based approach was all about developing a better sleeve, a sleeve that had a more tubular shape, that didn't have twists, that didn't have indents, that didn't have narrowing in certain areas. The goal was to produce an optimal sleeve. And when you get an optimal sleeve, you have better results.
Yeah, that makes total sense. And then, John, to build on that a little bit, in the study that was recently published in Obesity Surgery, you talked about how the Titan SGS stapler showed significant benefits over other surgical staplers. Can you walk us through some of the key findings in that study and explain how these might result and influence surgical practice moving forward?
Sure. I think, first of all, it's important to understand the difference between what we do with a Titan and what we did before we had a Titan. So when we create a sleeve gastrectomy, basically we're removing 80% of the stomach by dividing the stomach along something called a bougie, which is a tube that's placed down through the mouth all the way down to the bottom of the stomach. And we staple along the outer edge of that to remove the outer part of the stomach. Traditionally, that was done with multiple staple fires. The traditional staple was only 60 millimeters long. And so since that distance is much more than 60 millimeters, you had to fire that staple many times in order to create that sleeve gastrectomy. And the problem is when you're firing a stapler multiple times, you have to readjust absolutely every single time you do that. So really, every fire is correcting a minor mistake that was made in the last fire. And the sleeves that resulted, although maybe the majority of the time looked good, you had a significant number of times where you had rotation of the sleeve, or you had narrowing at a certain portion of the sleeve, widening at certain portions. The sleeve just wasn't a perfect tubular sleeve. And there were studies that had been done throughout the country that looked at, what's the rate of getting a perfect sleeve when you do that? And the rate was really almost always less than 50%. So the idea of the anatomy-based approach and to be able to develop a device that would divide the entire stomach was, can we make this sleeve more tubular? Can we make this look perfect every single time? And that's really what the device has done. And that's what our study showed, was that we can now create a great looking, great functioning sleeve every time. And when you do that, the operation doesn't take as long and the results are better. The patients have less nausea. They have less vomiting. They go home sooner. They are less likely to be readmitted to the hospital. There's less leaks and there's less bleeding. So all of the things that we look for to make the results better for patients, we can achieve when we have a better sleeve, and we can create a better sleeve when we have a single staple line.
Yeah, that's fascinating. I'm thinking as you talk about that, because I've seen some various types of surgeries, and I'm thinking about all those fires, right? That's going to be very tedious to try to get that exact placement, right? And with especially thinking about the changes in anatomy from individual to individual, right?
Right.
Am I heading down the right path with that?
Well, you're exactly right. And not only that, but it's not only what the surgeon does, but it's how the assistant pulls the tissue into the stapler. It's how thick the tissue is. And, it's a matter of you staple, then everything's got to be recalibrated for the next staple. So there's just so much variability. And the beauty of this is we can get this whole thing set up. We can align everything perfectly. And before we fire the button to actually fire the device, we can look at it from the front. We can look at it from the back. We can look at it from top to bottom. We can look at it from multiple ways and be assured that that sleeve is going to be perfect before we even fire the button. The carpenters talk about measuring 3 times before they cut. And that's really what we can do now with this, which we could never do before, is we can look at this in multiple levels, multiple angles, and say, that looks perfect before we even hit the button and fire the device.
That's very helpful. And James, back to you. Dr. Schramm talked about the study and the highlights for improvements in efficiency. So how does that efficiency reduce nausea and vomiting and perhaps fewer hospital readmissions? How do you see these findings impacting the adoption of the Titan SGS stapler across various healthcare settings? Can you give us some insights into how that's going to help you and your team?
Sure. Yeah. So I think the biggest thing that comes through as you're starting to build your clinical evidence is really to take something that is new and different. And most aren't eager to try something new and different, right? When they've been using something, they're customary to it, they're comfortable, right? With that, what happens with evidence is it gives a rationalization for why you should try it, because it directly will impact patient experience, which is so critical and important. The other efficiencies build upon that, whether it's reduced OR time, reduced length of stay, but it's all about that patient experience. And I think those are the things, and that evidence is what gets people to say, you know what, I think I'm ready. I'm ready to try this thing, because there is that hurdle, that psychological hurdle that surgeons have to go through when they say, but I'm good. I'm comfortable with what I'm using today. And so it just gives them the energy and motivation to try something new, try something different. Because like with any innovation, right, there's a learning curve that you have to go through. And I think most aren't energized by having to learn something new when it's, in essence, doing the same surgery they've been doing year after year after year. And I think with this evidence, it just builds that credence to say, it's worth trying. And we've seen that in the early days of this publication being out there in the public.
Yeah, that's exciting to hear, because many of us in the medtech industry have had some of those challenges. So I can appreciate having that kind of evidence to work with. That must be very exciting and invigorating for your team.
Absolutely.
Yeah, I love it. So, Jon, coming back to you, I kind of have to ask this question. Looking at the news lately, one would think the GLP-1s out there were like the magic potion. So, being a bariatric surgeon, I'm kind of wondering how you see these drugs and how they have an impact on the clinical need for bariatric innovations and procedures. Can you give us any insights in terms of how that's all connected out there, and is it having an impact from your perspective?
Yeah, I think nationwide, we saw a reduction in the amount of surgery that we were doing, largely because everybody thought this was going to become the magic potion, so to speak, that we could avoid operations and that we could treat everybody with shots. And I think it's done a couple of things. One, it's given primary care in patients, I think, the understanding that obesity is a disease. For years and years, obesity was treated as a failure of lifestyle or a failure of will. And I think very few people understood the actual disease nature of obesity, the fact that it's a physiologic problem. And I think one thing has been good about the GLPs for us is that it's helped people understand that obesity is a physiologic disease, right? I mean, if we can treat this disease with a medication, with a hormone, well, it must mean that there's a hormonal problem that needs to be fixed, right? So it's helped people understand that obesity is a disease that needs to be treated. Now, unfortunately, GLPs are not going to be the magic potion for everybody. They help people lose maybe 15, 20% of their excess weight, which for the average bariatric patient is not enough. I mean, our patients need to lose 30, 40, 50% of their excess weight or more. And so the GLP in itself doesn't quite do the trick. And I think people will find out that the GLPs will not be an adequate treatment program for people who need to lose 60, 70, 80, 100 pounds or more than that surgery will be a better option for that. And we've been able to show, and there have been plenty of studies out there now that show that surgery is not only the most effective treatment for severe obesity, but it's the most cost-effective treatment for severe obesity. And insurance companies are starting to understand that too, but it's a very helpful adjunct to us. We can use it preoperatively to help people lose weight to make the operations a little bit more safe. And we use it quite frequently now postoperatively at patients who we may have phenomenal results with surgery, but then start to have a little bit of recidivism or don't lose all the weight that they want to do. And so we can add a GLP to try and augment those results.
Yeah, that's interesting. I like the kind of creating some awareness for the community at large, but also was thinking too, up front, does that help perhaps make them a better surgical risk by losing that 10 or 15%?
Well, certainly the patients, with a BMI over 60, we like to put them on a GLP and, have them get into that BMI 50 range before we do surgery. Makes the operations technically much easier. And when the operations are technically easier, we usually can do it a little bit safer.
Yeah, that's really helpful. And then James, over to you with that same GLP-1 topic. I'm wondering, from your end, when you're developing this product, was the business case maybe tougher? Kind of getting the resources, the investment, and everything from a product development standpoint. Was there an attitude of, wow, we got this magic potion now, and we don't need to do this anymore? Did you run into those barriers?
Well, I would say, Tom, timing is everything in this reality, right? Because when we started to see, I'll say that strong momentum of GLP-1 use really, become visible to the public, Titan had already been launched. So, in reality, it was about a year and a half prior to starting to see GLP-1s gain some momentum in the marketplace. So, to that extent, it did not impact, our focus, our investment, the resources we were putting in place. And quite frankly, even with that phenomenon, and as Dr. Schramm had indicated, right, there was a little bit of a backstep in surgery that happened in those early days as people were trying to figure out where this fit within the care pathway. We continued with, focusing in on investments around the introduction of, buttress material that goes along with the stapler, as well as a tapered bougie that optimizes that optimal sleeve shape. So we continued investment in those innovations, have launched them at the beginning of this year. And so, we continue to focus in on it. And just from a resource deployment perspective, it's critical that you have the appropriate resources in place, especially when you're introducing a new technology, because you've got to provide optimal service to surgeons as they are being introduced to the technologies and in that early part of the learning curve.
Yeah, that's, I think you might have found, we often hear that the gurus out there talking about sometimes it takes twice as long, right? So is that one of the things that you had to prepare for, is maybe that length of adoption?
Yeah, I think it definitely slowed down some of the momentum. Fortunately, because of it being so early on, you could still grow even despite the fact that you had it reduced. And when you're at a low point from a market share position, you're not trying to claw back things you're losing because it's all about gaining. And so we had a different metric than maybe those that had been in the market with their stapler for years and then really felt that phenomenon change. We were still in the upstart period. So it was still a momentum building period for us.
Yeah, I can see that. And Jon, I wanted to come back to you from a patient selection standpoint with some of the significant results you're seeing, such as a 30-day, reduction in hospital readmissions after 30 days, lesser nausea and vomiting. This is a big decision for a patient to make. Are these findings helping to address patient concerns and helping you with patient selection and getting folks involved in your program?
Yeah, certainly. We tell patients now that we can do this operation just as safely as we can do a laparoscopic cholecystectomy or a gallbladder operation. And I think that's probably always been the greatest impediment to patients coming to the operating room. Do they believe it was a disease or do they believe it was their fault? Was probably number one. And number two, can this be done safely? And can they be guaranteed or assured that this would be a simple and safe operation with a good outcome? And I think the more that we can do on the technology side to create an incredibly safe operation, the better this is going to be. Patients communicate with one another. They're on Facebook chats with each other. There's apps dedicated to sleeve gastrectomy. And I think for every good result, there's probably one or two referrals. But for every bad result, there's probably 10 people who say, I'm not going to have that operation because of what happened to so-and-so. So the more we can do to limit those bad outcomes, certainly it's going to be better for the overall field of bariatric surgery. And I think that's what this technology does. It makes it so that every surgeon can have a great outcome, because this really makes it so easy to have a perfect sleeve. I think we'll see better outcomes across the board, and it'll be great for the field of bariatric surgery.
Yeah, that's fantastic. And with that, James, I wanted to come back to you too, because surgical value analysis is a reality today. So I'm just kind of curious, you're talking about some faster discharge times and some other patient-enhanced goals, reducing healthcare costs. Is the SGS stapler, aligned with those? Are you finding the surgical value analysis to realize some of those gains and maybe helping you get through some of those doors quicker?
That's a great question, Tom. I think one of the things we have to know is in the early days, it was really about focusing in our messaging around the technology and what we believed in. I would say that was a little tougher hill to climb, right, with value analysis committees, because it was our campaign. It was our messaging. Now, when you have clinical evidence that backs that up, that you're seeing in real world evidence through the utilization of the Titan within sleeve gastrectomy, that conversation becomes a lot easier when you can point to clinical evidence rather than it being a company's motto around the technology itself. And so we've taken what was messaging and what we believed just in how the innovation was developed, and now we're able to speak to it on real world terms.
Yeah, that's got to be very helpful in trying to communicate some of that. And sticking with you for just a moment, James,
Sure.
Bringing that innovative technology like the Titan SGS stapler, there's some significant challenges, I'm sure. So our gurus out there are always interested in some of those challenges and how you overcame them. So can you share with us maybe a story or two about some of the challenges you faced in those early days and then how you overcame them?
Well, I think the the biggest thing was really, so when you look at this stapler, and maybe even Dr. Schramm could give his first overall experience with it, when you see this stapler, because it's a large stapler, right? Because it is a single staple line. So it's encompassing the entire size of the stomach. Those early on is, oh my goodness, that is a big stapler. And, kind of that shock and awe, and then saying, wow, what size trocar am I going to need for this thing? And you talk about a 19 millimeter trocar, and they're like, wow, that is significant in size. And so there's a lot of those, that immediate feedback that become that barrier. And it's really the focus in on staying on message and really that commitment to, we just want you to try it, because what we have found is it is a profound experience. We call it the wow moment. And that wow moment is when they get that first experience of using the Titan stapler and seeing that stomach post-stapling, post-dissection. It is truly one of those enthusiastic moments, not only for the surgeon, but for the whole entire OR staff. But I think the biggest thing was just, again, as I mentioned previously, it's that really that desire and hunger to change is the first barrier you have to face. And that's where that messaging and evidence really helps out. But then we had to go through, wow, the size, that's pretty large. And then when you walk them through that and understand that trocar size may actually be good for you, because as you're wanting to extract that stomach, now you don't need to upsize or stretch that defect to try to remove the stomach. You can do so and then be able to suture it up and do so efficiently. So I think those are some of the main things that we had to overcome. And I think, as I would say, the biggest thing is, and I mentioned this earlier as well, is having that support, whether it's your advocates, right? Your KOLs, your early users that can speak to it firsthand. They've been in the OR with the device and they can really share their experience and provide some great tips along the way from a technique perspective. And then having a strong, clinical and sales team to really be there and focusing on it. And it's, again, thereafter, it's about maintaining visibility.
Yeah, that's very helpful. And Jon, I got to come back to you with that and maybe put you on the spot a little bit. And forgive the phrase, but when you first saw this, did it give you any heartburn when you first saw the size of that stapler?
Well, I had been kind of prepared for it. And as Tom said, the 19 millimeter trocar didn't scare me because we had been using a 15 millimeter trocar, which was only slightly smaller. And we usually would have to stretch that thing open to get the stomach out. It was early on realized that the 19 millimeter trocar was actually going to be a benefit. It's very easy to place in the belly, and it does make it so much easier to get that stomach out. Getting the stomach out can sometimes be a real difficult part of the operation. Now that's a very easy part of the operation with this 19 millimeter trocar. But yeah, I mean, when you first put that Titan in your hands, you realize you've got something, pretty significant. And it was, how's that going to fit in the belly? But the reality is it really works well.
Yeah, that's fantastic. And sticking with you just for a second, Jon, with that, a lot of our gurus out there are innovators, and especially since COVID, they talk about it's difficult to get access to clinicians. So if somebody approaches you, what type of homework, what do you like to see them to have accomplished before they contact you? Can you give our gurus any guidance in terms of approaching an accomplished clinician such as yourself?
Well, I mean, if you're talking about new technology, having a really good understanding of what the problem is and what their idea is to solve the problem, right? I mean, most of the problems that we face in surgery, we've got solutions for already. This was, when I first saw this whole concept, and it was probably in 2017, I was actually a KOL for another company who asked me to evaluate the whole concept of an anatomy-based approach. And I told them immediately, and this was at the ASMBS conference in Washington, D.C. at the time, I came back to him, I said, this is the one thing at this entire convention that has the potential to be a paradigm shift. This will change the way we do surgery because this is innovative, but it's also not just innovative, but it's innovative with the right idea of making this operation better. And that's what, it's not just about new technology for new technology's sake, but new technology that will improve the outcomes. And it was very clearly evident to me from day one that this had the potential to improve outcomes.
Yeah, that's awesome. And for both of you, and Jon, I'll just stick with you for a moment for this question, and then James will come to you. But looking ahead, Jon, what do you see for the future of bariatric surgery and evolving? You kind of touched on the fact that people are recognizing it now, perhaps more of a disease. How do you see that playing out in the future? Or do you see the awareness building?
I think that's the main thing that we as bariatric surgeons need to work on is the education piece to not only patients, but to the primary care community, that obesity is a disease. It's not a failure of lifestyle. It's not a failure of will. It's a disease that needs treatment. Just like we treat diabetes and we treat hypertension, we treat sleep apnea. We don't tell people that they just need to go out and diet more, exercise more. We need to treat the physiologic problem. And the same thing is true of obesity. We now know that obesity is caused largely by genetic problems, and it leads to physiologic abnormalities. And we can treat those physiologic abnormalities with surgery or with medications. And most people don't realize that the operations that we do actually correct the physiologic problems inside the digestive tract that lead to obesity. And I think that's really the message that needs to come out to patients now, is that you have a disease that needs a treatment. It can't be treated with just lifestyle changes, but the operations that we do can actually affect and can fix the hormonal problems that are leading to your disease. And if you can fix that, and then when people understand that, it's like, well, really, it's a no-brainer to have an operation to undergo something that needs to be corrected. But when they feel they're having an operation to just because they had a failure of lifestyle, then it's a lot tougher sell. So that's really the main message we as an industry need to do, is to make people understand this is a disease that needs treatment.
Yeah, that makes total sense. And then James, over to you. I'm just going to modify the question a little bit.
Sure.
I mean, what role do you see with continued innovation like the Titan SGS stapler? What role do you see that innovation in the next generation of surgical procedures? Can you give us any insights there?
Well, I think the biggest thing, right, in anything you look at from an innovation perspective is to truly understand within each specialty, within each procedure, what is the experience for the surgeon, for the patient, for the OR, for the hospital, to really identify where those pre-existing pain points are, and then really looking at technology as a pathway to ease some of that, whether that's improving the patient experience post-operatively with outcomes, with pain, nausea, those types of things, whether you're looking at how do you improve and put tools in front of surgeons to help them continue to strive for creating better outcomes for the patients, reducing their OR times, right? So they can continue to focus in on performing more and more surgeries where that's possible. And then I think overall, it's how do we drive towards reducing overall healthcare costs, but not by shortchanging any of those elements that I mentioned previously. And that's really that perfection of innovation, is when you can drive those optimal outcomes for the caregiver, for the patient, but also drive efficiency in the hospital. That's when you've hit that sweet spot from an innovation perspective. I think as we start to see more and more technology out there, we have, with artificial intelligence, let's see where this takes us. It's an exciting time for innovation, and look forward to the journey.
Yeah, it is, and very well stated. So, gentlemen, I'd like to first of all acknowledge both of you for the time it took to prepare to be on the podcast today and be our gurus. Dr. Schramm, I'd like to start with you. If somebody wants to learn a little bit more about Corewell Health and your bariatric program there, how do we learn more? Is there a website? Are you? How do we learn more about you and your program?
Yeah, they can just Google the bariatric surgery program at Corewell Health, and we have our own website. And I have 4 partners. We have a great team, multidisciplinary team, and treat on both the surgical side and the medical side. And happy to help.
Oh, that's fantastic. And James, over to you. If somebody wants to learn a little bit more about you and your team, how do we do that? Is there a website? Are you on LinkedIn? How do we find out more?
So we've got, website, we've got teleflex.com. We've got our LinkedIn handles at Teleflex. We also have a Standard Bariatrics LinkedIn contact. So whether it's through the website or through multiple handles on LinkedIn, we are absolutely accessible.
Oh, that's fantastic. So once again, gentlemen, I really appreciate your time and insights being our gurus today.
Thanks for having us.
Thank you so much, Tom.
Thank you. Thank you for listening to MedTech Gurus. I am Sylvester Harris, your MC. If you want to learn more about Tom and his consulting services, you can go to www.pctmedical.com or email Tom at tom@pctmedical.com. Now, I can be reached at Sylvester Harris, that's SylvesterHarris 5048@gmail.com, and I'd be pleased to discuss any voiceover work that you may want for your company or broadcast. Hey, thanks so much for listening, and catch us on the next episode of MedTech Gurus.